Although this technique is still in evolution, we need to find out and have some further studies going as to find out what are the forces acting while the ramp lesion is caused. Is it translation or pull of a semimembranosus? But we definitely need to review that what are we really repairing? Are we repairing MCL, MTL, or are we repairing it to the meniscus? If MCL and MTL are the main anatomic structures in the ramp lesion, then they should be attached to the bone. And further biomechanical studies are required to validate our findings. You have any questions? Yeah.
So, isn't there any connection with meniscus in these ramp lesions? Because what we find is when we probe these lesions, there is some excursion of that posterior part of the meniscus in those ramp lesions. So, isn't it good to take bite from the meniscus as we always do rather than doing this thing?
So, if you consider the meniscocapsular ligament and the semimembranosus is supposed to be attached to the posterior part of the posterior inferior part of the meniscus. So if you feel that these posterior horns are unstable by doing a suction test or by probing it, one can definitely add a single all-inside suture from anterior side to stabilize this meniscus to the repaired capsule. So case number 2, 45 years female, swelling over the lateral aspect of the knee, pain on and off while getting up from sitting position, history of catching on and off. Pain was about 5 of 10. There was no history of trauma. There was lateral joint line tenderness. All special tests were negative, and it was a household. She was a household help. So she used to sit down and duck waddle while mopping the floor, which she was not able to do it. So I don't have a pre-op clinical picture, but this is a cyst. So this is a lateral meniscal cyst, anterior horn, and it was located onto this side just above the tib fib joint. So those were the MRIs. You can see that's a huge cyst lying there. And if you take them further, then you'll find that it is extending up to the level of the tibiofibular joint there. So it was a large multiloculated cyst which presented onto the lateral aspect of the knee. You can see serial pictures showing the extent of the meniscal cyst. And this is the film which I would like you to really concentrate upon. So if you see this kind of a picture, and that is the enlarged picture where you can see the lateral meniscus there and the cyst lying just outside the ITB at times as well. So can I have a second ARS slide? So with this picture, what do you think? What have caused the cyst? The cyst arising from the proximal tibiofibular joint, which was actually reported by my radiologist. Cyst, he's a MSK radiologist. Cyst arising from a lateral meniscus tear, sequestrated fluid in extra-articular region, or antero-inferior popliteomeniscal fascicle injury. So it's a cyst arising from lateral meniscus tear. More often than not, we really find these cysts arising from the lateral meniscus tear. But again, in MRI, there was no meniscal injury which was demonstrable. So there you see, now these fascicle injuries are very well documented and studied. We went through the literature as well. This is Smiglewski's zone 8 and zone 9. So these are zone 9 injuries, and those are the inferior fascicles. Parallelly, according to his anatomical studies, is quoted that these fascicles are very important for stabilization of the lateral meniscus onto the tibial plateau, and their injury could give rise to hypermobile lateral meniscus and symptoms of catching and pain at times. So this was one kind of unusual injury. Those are certain papers as regards the popliteomeniscal fascicle injuries, and probably we thought that if it is a tib fib joint arising from tib fib joint, then why it is anti-gravity? So the cyst was much more superior to the tib fib joint, and we thought this is not related to that. That was the arthroscopy picture. That's the lateral meniscus, and that's the inferior surface of the lateral meniscus here. So what we did is, we did a standard arthroscopy. That's a popliteus tendon. That's the inferior fascicle there, and we tried to probe that, trying to see for the injury. The suction test was positive. The meniscus was hypermobile here. So what we did is, we inserted a needle through the cyst and took the path of least resistance to find where it exits. And we found in the lateral gutter that it came out of the popliteal hiatus there. So thinking of this, if the needle passes through with the least resistance, we thought probably this is arising from the lateral meniscus and inferior fascicle. And that was the fascicle which you can see. I'm squeezing out the fluid from the cyst. So antegrade we went from the lateral compartment and we put a shaver in and shaved off this meniscocapsular junction to evacuate the cyst from inside the joint. Whenever we are dealing with this cyst, I always tend to see that I always squeeze it from outside as well, and we also put a shaver in from outside in to evacuate the cyst completely. So that was done, and then the shaver was put from the cyst outside the joint, and the whole track of the cyst was cleaned. And this inferior fascicle then was stitched with the all-inside device. So that is the inferior fascicle, and the rent in the capsule was closed. So that was the final repair which was done, and this patient we followed up further for the symptoms. The patient is absolutely fine. It was consistent with the cyst. That's the 3 months post-op. You can see full function. That's the incision where the cyst actually had, and that is the post-operative MRI which shows that now at this point in time there is no residual cyst left, and you can see the fascicle being repaired there, which you could see in the first picture. So to conclude, inferior popliteal meniscal fascicle injury is rare and difficult to diagnose. This may cause hypermobile meniscus and catching. MRI findings may not be consistent. Diagnostic arthroscopy should include probing of the popliteus and the fascicle to avoid missing these injuries. Suction test might demonstrate hypermobile meniscus.
So Dr. Milind,
Sir?
these are the chronic injuries?
This was a chronic injury.
Sir, like working from inside on the posterior lateral corner of the knee, does it give you a sense that we can injure sometimes CPN, it is lying at that location only, we are going blindly in that area only?
So the cyst is superior to the tib-fib joint. So I don't think inadvertently you would go there, and plus you get a limited trajectory. So until you have a limited trajectory, so you would hardly go about 3 or 4 millimeters below the joint line. So the basic function is to suck the fluid out and shave whatever you can from inside the joint.
Same thing I was asking. Typically we do it with an open procedure, going from outside. We can see the cyst, remove it right at the neck and then stitch it. So by putting it blind, our shaver, we would have done some bits of it removed. Would you be happy with that, or
So
would
as
the
you
open
could
one
see,
would do a better job?
So as you could see, what we did was, we did put the shaver from the cyst into the joint.
Sure.
So we did not put shaver blind. So it came through the path of the least resistance, which was above the tibiofibular joint. And it did come out through the popliteal hiatus near the fascicle. So it was, logically wouldn't injure any important structure there.
Sure. There's a total excision. Once you visualize and you remove the whole thing as compared to this, would there be any difference, you think?
I don't know, but I thought that, because since it is an intra-articular injury, I was reluctant to understand that this is a tib-fib joint cyst.
Yeah.
Because it is proximal to the tib-fib joint, and a cyst will not anti-gravity get collected there. So I thought it is probably arising from the lateral meniscus, and that was my sole purpose, to do an arthroscopy to see what is happening there. And there is literature to support this, because these in arthroscopy techniques have been described by few people by repairing these fascicles with all inside devices.
Yeah, so that's absolutely good. What I was saying was that what we do typically for the big meniscal, lateral meniscus cyst also, we do an open removal of the cyst from outside and then go from inside and either repair or remove the meniscus or repair it. So it is
my always a practice that whenever I am dealing with a cyst, I would do intra-articular as well as extra-articular, and then repair the rent and come out. So do we have time for the last little discussion?
Can we have these questions?
Yeah, sorry.
Just taking the same discussion ahead, in the last point you mentioned, summarized that you would like to stitch it both outside and from inside. Taking the same discussion forward, sometimes you see these cysts arising from the anterior horn, or starting from the mid-body going up to the anterior horn. And more often than not, once you try to do this dual approach, you realize that the capsule is extremely flimsy there, and then you're very worried as to how to stitch these menisci.
So Nagaraj, we'll just finish this case and take your question.
So
this relates to the same
another
question.
statement on this, especially these cysts, which sir was saying, it's a rather precarious area. Intraoperative ultrasound helps a lot. So when you put your probe there, you'll know exactly where to probe.
Point taken.
Just one small comment actually. If you, we did a cadaveric study on this, passing a straight needle anterior to the popliteus tendon. If you keep the knee extended, there's a good chance you could injure the common peroneal nerve. So if you keep the knee flexed, more than 90 degrees, and if more than 120 degrees, the chance of injury is not there, negligible.
So it's 90 degrees plus.
Is it your last case?
Yeah. So just because I have to answer Nagaraj's question.
Can we
So
finish it
50
quickly?
years female, only 5 minutes, not even 10. Swelling over the anterolateral aspect of the knee, kneeling was painful, difficulty in getting down the stairs, fluctuant, tender, special tests were negative. That's the cyst which Nagaraj is talking about, anterolateral aspect, very, very common. And you get a lot of huge cysts like this. They are in communication with the anterior horn of the lateral meniscus. Technically, they are difficult to treat because now here it is pressing onto the Hoffa's fat pad as well. Technically, they are difficult because the capsule is very flimsy there. Now, this is a mammoth cyst where you can find that both anterior horn, the medial and lateral meniscus, both are involved. So, I will not go to the ARS question here. I'll just go to the methods, how they are treated. Now, this is what we found. Now, here you are repairing this anterior horn with the help of a suture anchor. This is a 2023 article. And this is a classical Rob Laprad's technique outside in using PDS. The limitation here is a thin, flimsy capsule. You are not very sure what you are repairing. Plus, you have sutures which are just subcutaneous, and they sometimes can hurt. So, we have presented this technique of repairing anterior horn. So, that's the anterior horn of the lateral meniscus there, and that is the cyst. So, you come from within the cyst into the joint with a spinal needle, put your shaver in, take off whatever you have there. So that's the needle coming in, shaver coming in now from there, and then you shave off the whole cyst wall here. We also took a biopsy to confirm that this is a perimeniscal cyst, and that we normally do. Now here what we wanted to prevent was strangulating the anterior horn by the method which we saw previously. So once you shave this off, you are left with the anterior horn of the lateral meniscus, and you are left with a thin capsule. So that's a patellar tendon, retropatellar area, that's the anterolateral aspect of the tibia. So that you find that is a meniscocapsular junction. So what we did is we took a mattress suture configuration with the help of a first pass mini. So that's the capsule, that's the bone, and that's the anterior horn of the lateral meniscus. So we did a parachute kind of a repair here, taking 2 bites and 2 horizontal stitches covering the maximum length of the anterior horn of the lateral meniscus along with the capsule. And once this was done, to just take it a little fast ahead. So that was the way how the sutures were taken. And then you take this through a knotless anchor and you insert that knotless anchor onto the anterolateral aspect of the tibia. So here what you're doing is you're securing your fixation. You're not strangulating the meniscus. You're repairing the meniscocapsular junction, and you can rehab these patients early, as you need not be afraid of the capsular structures giving way. So that was the technique. This is also submitted and accepted by arthroscopy techniques. So that's a 4.75 knotless anchor which goes in, and that is the final repair. So
thank you.
That is the final repair there. Thank you.
Can I
Very
just
nice
ask a
presentation,
question?
Dr. MILIND.
Can I ask a question? The
One last question and then we
anterior body has to move by about 1 centimeter or 2 centimeters postally in flexion. The lateral meniscus actually goes over. So if you put it too tight in front, sometimes you hear, we're doing repairs like the Laprade, then patients say they felt a pop and they felt better. So I'm wondering, do we need to repair these anterior?
We fix this about 90 degrees of flexion. So extension, it does not create any issues. Post flexion, it might. But then until now, it hasn't caused. But your concern is absolutely right. But then in the similar fashion, these PDS sutures also might give way because the capsule is so thin and flimsy there that most of you will agree to me that you are never confident after doing outside in repair for anterior capsule.
Thank you, Dr. MILIND.